Thank you very much. Today I will be talking about predictive models of hepatocellular carcinoma in hepatitis B. Now, hepatitis B represents quite a unique challenge in terms of hepatocellular carcinoma because in addition of the risk of HCC secondary to cirrhosis that most patients with liver disease have, about 20% of HCCs in hepatitis B will occur in non-cirrhotic patients. Also, in specific settings, as I will show you in a few minutes, HCC in HBV can occur early in life. This is thought to be secondary to aflatoxin presence and viral integration. And that leads to an age-dependent risk of hepatocellular carcinoma in hepatitis B. Now, what do the guidelines recommend in this regard? And here we're not talking about risk stratification, we're talking about surveillance. Basically, the AASLD recommends for non-cirrhotic patients with chronic Hep B, men and women from endemic countries should start being surveyed after age 40 and 50. Persons from Africa at an earlier age, and you can see this already a bit in specific, people with family history of HCC, and those with a page B score of more than 10. At the middle of the presentation, I'll explain to you why they use particularly this score in these guidelines. Looking at the APASL guidelines, they're very similar, only that they have more specificity in when to screen people from Africa, and they don't mention any of the scores. Now, I want to focus a little bit on that recommendation from Africa. Why is that performed? There are several studies. This is one we did with the team of Louis Roberts a few years ago with 12 countries in Africa. We found that about 40% of HBV-related HCC will occur so under the age of 40. My team did a similar study in Latin America, and we found that 30% of patients with hepatitis B-related HCC develop so before the age of 40 as well. So there are certain populations worldwide that have a higher risk of developing early HCC, and it's important to understand that a lot of the scores that I will be talking about do not incorporate this population, so that's a very big gap. Now, why is hepatitis B so unique in the risk for HCC? We have a bunch of risk factors here I want to walk you through. The first two are very important. Family history of HCC, male gender, and age. Those are some of the most powerful risk factors for liver cancer in this population. And actually, if you are an older male with a family history of HCC, you have 4 times an increased risk of HCC compared to other people with hepatitis B. Alcohol consumption and aflatoxin exposure are also modifiable or preventable risk factors. And then we have some clinical ones like the DNA viral load, fibrosis stage, and with a bit of controversy, the genotype of hepatitis B has an impact. So what is clear is that we need better risk stratification for HCC in patients with hepatitis B. And I want to be clear, I'm not talking about surveillance here, I'm talking about stratification, knowing who's at higher or lower risk. What tools do we have to understand this? A popular tool that we have is genetic assessment. We do have single nucleotide polymorphisms, like my previous speaker said, also rare genetic variants. STAT4 has been largely studied in this regard, but the problem is that these genetic variants take upon only one aspect. And that's why a lot of researchers studying in 2010 and develop risk scores that incorporate multiple variants. We'll talk next about these risk scores, but I'll also talk at the end about artificial intelligence and the potential role in this risk stratification. Now, when we look at HCC prediction scores, there are too many. I can tell you right now there are over 20, so it's really overwhelming to go through all of them, and I don't think it's actually effective. But there are some common aspects that I want to emphasize. Basically, we have prediction scores for people that are off hepatitis, so they are not on hepatitis B treatment, and people that are on hepatitis B treatment. The great majority of these scores have been developed and validated in Southeast Asian populations, particularly Korea and China. There's minimal work on Caucasians and actually none in Latin American or African populations. They all, pretty much all of them, have a mix of laboratory and clinical variables. One of the few exceptions I'm showing you here is the CAM-D score, which includes cirrhosis, age, male gender, and diabetes. And if you're ever in need for a score that doesn't have any lab values, this is a reasonable one. And the goal of these scores is to identify patients that are at very low risk of HCC in the setting of hepatitis B so that we don't have to survey them. That is important to keep in mind. What I didn't put here, and it's important, is that none of these scores, at least the ones I'm aware of, include muscle D or steatotic liver disease in the picture. And that is a problem, as we know that hepatitis B and muscle D is becoming a more common problem, basically, that can lead to earlier HCC. Now, this study shows on the left at least 14 of the scores that we have. And if you look slightly to the right, the box in red, the great majority of these scores rely on age and gender to stratify the risk. They add later some sort of medical history, and then at the end a different combination of laboratory values. But really, age and gender are king and queen of risk stratification for liver cancer in hepatitis B. I will talk about two studies in the next few slides. This is a systematic review and meta-analysis that was done in 14 models of liver cancer for HBV, looking at 120,000 patients. And the authors first developed a calibration model to see how these studies work, and also had an external validation in their own cohort. Please keep in mind that external validation is also of Southeast Asian origin. So what they found was that among all these 14 scores, the real B score was the one that performed better at 5 years, not only in the calibration section, but also in their validation cohort. Now, what is a real B score? For those of you not very familiar, it's a score composed of 7 different variables that leads to 3 different categories where it puts you at low risk, medium risk, or high risk of HCC. Now, I'm going to go back to this slide just to show you how complex this is. Because if you look closer to the scores, they're not all the same. So 4 of these scores are on patients that are not on treatment. And actually, the REACH B score, the first one you see there, that was one of the first scores developed, is the only one developed for patients that are non-cirrhotic, not on treatment. Only 6 of these scores had a significant validation. So really, in only 6 of them, you can calibrate properly the risk stratification approach. And then only 4 of them had really more than 1 or 2 external validations. So once you start looking a little bit closer, you can understand the complexity of using these scores for risk stratification. The second paper I want to bring you to is one a little bit older, coming from Italy. This paper looked at 12 different models, and what they did, they assessed the applicability beyond Southeast Asian scores. And basically what they found here is that the page B here on the lower right was the best score. Now, if you know a little bit about scores, this makes sense because the page B is the only score that was developed in Caucasians and later validated in Southeast Asians. All the other scores are really the opposite, with like actually 1 or 2 only validated in Caucasians. But if you look at the page B score and you look up here to the right, you can see it has a negative predictive value of almost 100% of developing HCC at 5 years. And that is a reason why the ASLD, where is the only score actually endorsed by the ASLD. Page B score is also simple in a way. It's composed of 3 variables, age, gender, and platelets, that again put you in 3 different categories: low, medium, or high risk of HCC. Now you might wonder how you can get so many points with 3 variables only, but if you look in detail at the score, you really have to work a little bit in getting some of these points in there because you get different points based on age and different platelet counts. So if I were to wrap up this part of HBV HCC scores, I would say that if you have patients that are not on treatment, the REACH B is a reasonable score. If you are patients on treatment for Hep B, the real B and page B are good scores. Keep in mind that page B is the only one validated in Caucasian and Southeast Asian populations. And if you're looking for a score with no labs, the CAM-D score is actually quite reasonable. Now, the next few minutes, I want to talk about artificial intelligence in HCC. I put surveillance here as a mistake, that's stratification, sorry. There's been a lot of talk about AI in this meeting and in a lot of meetings, as I think we all can agree that's the future. The way I look, or a lot of us look at AI, is based on three ways in this aspect related to cancer. One of them is mass and cancer. That's easy to grasp, right? You see a mass, you ask the machine if this is cancer or not. For our purposes, this is not helpful because you need to find a mass first. The second aspect that we look for artificial intelligence is the unconventional use. My team has been using Doppler ultrasound assessment via AI with some good success to understand HCC risk and development. Dr. Kamath talked about the use of EKG to assess the risk of cirrhosis. So we can use this kind of unconventional tools that don't come to mind easily, where the machine can perform better than we do. And then specifically for risk scores, there's been quite a wave of multi-parameter assessments that help us stratify the risk for liver cancer. For this, I want to bring you to this paper published in the Journal of Hepatology 2 years ago. It's called the Plan B model. And what the authors did here, they fed certain variables to a machine learning algorithm that picked up 10 of these variables. These variables were all present before started treatment with Hep B for these patients. They developed this in a Korean cohort, validated it in a Korean cohort, and then validated it in a European cohort. What they found basically is that their Plan B score, the machine learning assessed score, performed better in Korea as well as in Europe. You can see in Plan B to the upper left with a C index of 0.79 for Koreans, and the Plan B on the right with a C index of 0.81 for Europeans. Now this is quite exciting, but keep in mind that the Korean population has been studied before in other cohorts of HCC prediction, and the European one is the same cohort that used the page B score, which brings another layer of complexity, is that a lot of these scores are being tested in the same populations worldwide. But I do believe that this kind of approach will give us, in the next few years, some better answers. The problem with this approach is that the machine, and I talk of the machine as this Terminator, but the machine is actually taking on the variables that we humans provide the machine. I do believe, and a lot of us believe, that an AI-derived parameter, not assessed, so basically an algorithm that is developed by a machine learning model and the machine picks variables, could be much better in the future to help us risk stratify patients with Hep B at risk for HCC. So, a summary here slide. Most scores that we have aim at identifying patients at very low risk for HCC. This is important. If you're going to use these scores, I don't advise you to use them to see who's at a higher risk, but who you shouldn't be surveying. There's no score validated in all populations. Actually, majority of scores are validated and developed in Southeast Asian populations, and none of them have been studied in African or Latin American populations where early HCC is a problem. For patients not on treatment for Hep B, I think the REACH score is a reasonable score as long as you understand the weaknesses. For patients on hepatitis B treatment, the real B and the page B score could be of use. And again, if you don't want to use laboratory variables, I think the CAM-D score is reasonable. Again, I will repeat that none of these scores assess the presence of muscle D or steatotic liver disease, and that is a bit of a problem. And I believe that multi-parameter scores derived from artificial intelligence is likely to represent the future in this case. And with that said, thank you very much.